Hello, I'm Bruce Gewertz, Vice Dean for Academic Affairs and Chief of Surgery here at Cedars Sinai, and it's my pleasure to welcome you to another edition of our Pioneers in Medicine. Today we have the great good fortune of talking to Keith Black, our distinguished professor of neurosurgery and a real leader in the treatment of brain tumors and other nervous system pathology. Keith, welcome.
Thank you, Bruce. It's a pleasure to be here.
Well, one of the things that's so rewarding about these sessions is hearing a little bit about the personal background of our leaders here. I wonder if you could tell me where you grew up and went to school and trained.
Absolutely, Bruce. So I was born in Alabama. My parents were educators, and this was actually during sort of the earlier civil rights era. And they were very involved in that period in the 60s. And we moved from Alabama to Cleveland, where I went to middle school and high school at Shaker Heights High School. And after Shaker Heights, I was admitted to an accelerated undergrad medical program. It's a 6-year program at the University of Michigan, where I received both my undergraduate and MD degree. Stayed on at Michigan for my neurosurgical residency there. And after that, joined the faculty at UCLA, where I spent 10 years and been here at Cedars Sinai for the last 22 years.
And it's been our great good fortune to have you. One of the most incredible things about your history, of course, is that, as you remember, you were a medical student of mine when I was a resident at Ann Arbor, and despite that age difference, we've become the same age as time has gone on. How did you get interested in, first, neurosurgery?
So neurosurgery really stemmed from my fascination, Bruce, with the human brain. During my first year in the program at Michigan, I would have essentially been the level of a freshman in college. I had my first course in neurochemistry and neuroanatomy, and just was floored by the function of the human brain, the complexity, the beauty of it, the intricacy of it, the fact that it actually gave us the essence of who we are, our memories, our personalities, our ability to create, our ability to feel, and that function. Became very interested in the process of consciousness, how electrical and chemical impulses between cells converted to this conscious experience that we have. So that was my early fascination with the human brain. And if you have an interest in neuroscience, there are sort of three main avenues. One is a pure scientific career, where you're studying, structure, function, mechanisms of the nervous system. The other is in the medical treatment of neurological disorders, going into neurology. And the other sort of major pathway is in neurosurgery. I love to work with my hands. I love the disorders that neurosurgeons treat: brain tumors, vascular abnormalities, epilepsy, Parkinson's disease. So that was my real attraction. I love the disorders. I love the precision and the preciseness of neurosurgery. And I love the ability to have an impact on patients with devastating challenges.
Well, I know you're one of the world's experts in brain tumors and have personally performed a very substantial number of operations in brain tumors. And I also would imagine that there's been a tremendous change in the treatment of brain tumors since your practice began. I wonder if you could tell us a little bit about how you viewed that evolution in treatment of brain tumors.
So, when I was training as a resident in neurosurgery, the thing that my wife would always tease me about is that neurosurgical patients had terrible outcomes, right? They came out of surgery with neurological deficits. They were, we had patients, it was not uncommon to have a 2 or 3 week stay in the neuro ICU after surgery, months of recovery. Our ability to understand how to get to areas of pathology within the human brain without disturbing the critical and eloquent functions of the brain has essentially revolutionized our ability to treat our patients. So, I treated a patient earlier this week with a very large brain tumor, and they're up walking immediately after surgery and home in 2 days and back to their function, of their careers and normal activities within a week after surgery. It's quite dramatic. The precision, the ability to be minimally invasive over the past number of years, and the ability to actually treat patients with very big tumors and complex abnormalities within the human brain and have them essentially wake up from surgery normal or better than they were before going in.
Let's talk a little bit more about the actual therapy, and then later in the discussion I want to get into what the causes of brain tumors might be. What do you think has been the single biggest development that has enabled the safer surgical treatment of brain tumors?
Bruce, I would say it's really a combination of things. One is our ability to have precise localization of pathology within the brain, like tumors and vascular abnormalities with very exquisite MRI scanning. And the ability to combine that with sort of a GPS navigation. So we have functional MRIs, which is an MRI that can actually highlight the eloquent areas of the brain, such as language, motor areas, visual areas. We can reconstruct that in 3D and have a 3D reconstruction of where the tumor is located. We can also know in 3D where those connecting fiber tracks are going between these eloquent areas. And we can now design very precise corridors that can sneak between these eloquent areas and take a tumor out without disturbing the complex function of the human brain. And the ability to do that under the microscope, under magnification, has dramatically improved our ability to deliver the best surgical outcomes.
Yeah, having observed you and your colleagues in surgery, it's really remarkable how the actual act of surgery has changed and become so much more precise. What are the other postoperative treatments that can work to lower the risk of brain tumors?
So we divide brain tumors into 4 major buckets. One bucket is a benign brain tumor, such as a tumor that arrives from the covering protective tissue of the brain, a meningioma or a pituitary tumor or some of the coverings of the nerves like an acoustic neuroma. Those are the common benign tumors. And surgery is really the definitive treatment for those tumors. Surgery can be curative in a lot of cases. And for most of those patients, they do not need any additional therapy. We monitor them with MRI scans. If the tumor comes back, we have other options like focused radiation. But in the majority of those cases, surgery can be definitive. The other 2 buckets are malignant tumors. And malignant tumors can be divided into primary tumors, where the cancer is growing from the cells within the brain itself, or secondary malignant tumors, where they come from other organs like the breast or the lung or melanomas. For those tumors that are malignant, surgery is only part of the strategy to treat those tumors. And so we rely on other modalities. Radiation, chemotherapy, immune therapy now is showing great promise in the treatment of these tumors. One of the things that has really changed over the last, I would say, 3 to 4 years is our ability to get very precise molecular characterizations of the tumor. Every tumor, even if it's called the same thing, like a glioma, we know that those subgroups within gliomas that have different molecular types allow us to precisely define a treatment that can target that particular subtype more effectively and allow patients to have better outcomes. So that is one of the things I think that has really been a major breakthrough in our strategies to really more effectively treat these tumors.
I've heard about so-called clustering of brain tumors, and there's been a number of patterns of brain tumors, and it's hard to know whether that's statistical aberration or
Right.
whether it's real. What do you think are the environmental causes that contribute to brain tumors?
Yeah. So, that's a very common question that we're asked. And unlike a lot of other disorders, that we treat in medicine, that can have a significant environmental impact, like lung cancer or things like that, only a small fraction of brain tumors we think are actually influenced by either lifestyle or environmental factors. There have been a lot of discussion about the association between the use of cell phones and malignant brain cancer. The data has fallen essentially both pro and con, and we have not had a decisive study to actually show a definitive association. A lot of the studies that have been better designed tend to be the ones that show an association between cell phone use and brain cancer. So I think I tend to advise people to be cautious and tend to use an earpiece, for example, and not put the cell phone directly against the ear, which is close to the brain. We know that for some types of tumors, that radiation exposure can increase the risk. So in the pediatric population where they've been treated with whole brain radiation, they have a higher incidence of meningiomas and other types of tumors. So exposure to radiation is clearly a risk factor. So there's a concern about dental x-rays, but again, that association hasn't been conclusively identified. And then there's always the risk of electromagnetic or radio frequency from high power lines and things like that, or toxic waste. And we've looked at those clusters, but again, the evidence has not been definitive.
Is there any promise of any genetic markers that might predispose a patient to brain tumor?
Again, we also know that for some of the benign as well as the malignant tumors, that there are families, that there are sort of genetic clusters, and there are actually genetic syndromes where people tend to get certain types of cancers that include brain cancer. And then obviously there are syndromes like neurofibromatosis or elephant man syndrome that's associated with brain tumors. But if you include all of the genetic abnormalities, they probably make up less than 5% of brain tumors, both benign and malignant. So most of the tumors that we see, we believe, are spontaneous. Given that we have trillions of cells that are dividing, that are changing in the brain, that lose that ability to regulate themselves and transform into either benign or malignant tumors for reasons that we don't yet fully understand, represent most of the cases that we see.
In many forms of cancer in particular, your first therapy is the most important. That is, you want a definitive procedure done. Is that true for brain tumors?
It's absolutely true, Bruce. So one of the things that we know is that it's critical, if a patient is going to have a good outcome, is to get everything optimized right up front. Right? So you want to make sure that you have optimal surgery, the best surgery. And then you want to make sure that that first line of treatment that you get is the right treatment for your particular type of tumor. One of the challenges that we have for a number of reasons, right, in terms of distribution of top specialized centers, restriction based on payer, insurance restrictions, a number of different reasons, lack of sort of consumer awareness on the basis of what patients understand, is that most consumers, most patients believe that a neurosurgeon is a neurosurgeon. If you're a neurosurgeon, you can treat brain tumors, you can treat vascular abnormalities, you can treat my herniated disc for my back pain. The reality is, if you have a complex neurological disorder, you need to go to a center that specializes in that disorder. 70% of neurosurgeons have 90% of their practice in spine. Now, they may do 1 or 2 brain tumors a year, but that's not the person you want to have doing a complex brain tumor. And if it's a small hospital, that's not the hospital you want to have your tumor performed in. So for routine things, a herniated disc, that general neurosurgeon might be more than sufficient to take care of your need. But for complex tumors, complex vascular problems, complex functional treatments that need to be done, we know the outcomes are better in the centers that have high volume, comprehensive teams that focus in those areas. One of the things, for example, that we do here at Cedars Sinai is that we have neurosurgeons that just specialize in tumors, specialize in vascular. And even our neurosurgeons that specialize in tumor, we subspecialize. So we have one surgeon that just does pituitary tumors, and that surgeon is doing 100 pituitary tumors a year versus the average neurosurgeon that may do 1 pituitary tumor every 2 or 3 years. So that drives quality, and that surgeon is supported by a whole team of comprehensive endocrinologists that's evaluating how to best manage those patients. And that really drives best outcome and best quality for patients.
That certainly makes sense. What research, I know that your department does a tremendous amount of research, and you have focused your personal research on brain tumors as well as Alzheimer's disease. But in the area of brain tumors, over the next 5 years, what research do you think will bear the most fruit?
So that's a great question, and I break that down into sort of 3 different buckets. The first bucket is how can we make the surgery better? So doing surgery, primary brain tumors, the gliomas, the common type that people think about when they think about an aggressive brain tumor like Senator McCain had or Ted Kennedy had. So those tumors, when we go in and do surgery, the margin is not clear. The tumor blends into normal brain, and it's very difficult to know where tumor ends and eloquent areas that are controlling language and motor function and vision begins. So one of the things that we're focusing on is using special optical technology that can light up those tumor cells that cannot be seen by the naked eye during surgery to allow us to do more complete and precise surgeries. It's a technique called time-resolved optical spectroscopy, which looks at the reflectance of light from cells that can within seconds tell tumor from normal tissue, which is a very promising technique. In terms of radiation, everyone has heard about the cyber knife or gamma knife, which is a way of focusing radiation and burning a hole onto tissue. But one of the things that I think is promising on the horizon is really going back to a strategy what's called boron neutron capture, where we can tag tumor cells precisely now based on targeted therapy with boron compounds, and then treating that with a neutron source of radiation. So now you have micro-focused radiation, and you can essentially kill a tumor cell in the midst of normal cells without damaging the normal cells. So that's a very promising avenue, and we're doing some research in that area here at Cedars, which is very promising. The other area which is rapidly advancing is what I call sort of targeted therapy or personalized therapy. One of the challenges of gliomas is that it's not one tumor. It's a lot of heterogeneity. There are different clones. Those clones can change over time and based on treatment. So the ability to precisely know what clones a particular patient has and designing a therapy that's based on those clones for that patient, personalized therapy, I think will give us better outcomes. And then the third bucket is really pushing the envelope with immune strategies. One of the areas that has really advanced, I think, over the last 10, 15 years is the ability to target the immune system to fight the tumor. Brain cancers are elusive to that strategy because they tend to fight back at the immune system and make the immune system suppressed and try to make it dysfunctional. So our ability to give the upper hand to the tumor by learning those mechanisms better, I think will be another very interesting advance over the next 5 or 10 years.
Well, Keith, thanks so much for being with us today. We're really grateful to the great work that you do here, and certainly wish you the best on this quest.
Well, thank you, Bruce. It's a real pleasure.